Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lily Shockney.
Hi, this is Lily Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Healthy Insights That Matter. Substance abuse and addiction kill 11.8 million people annually, more than all cancers combined. Today, I am with internal medicine and public health physician, Dr. Michael Fingerhood, who serves as Director of Addiction Medicine at Johns Hopkins Medicine. We are here to discuss the root of addictive behaviors and substance abuse disorder. So welcome, Dr. Fingerhood. Thank you so much for joining me today.
Thank you.
So I have a lot to ask you because this is a topic that, in my opinion, affects every single family in some manner. So let's start off with discussing, can substance use disorders occur at any age, or is this something that I think the media sometimes has a tendency to make people think it's for teenagers and young adults?
Classically, that's what people think of. And there's usually some precedent that makes that the predominant thought. So it is true that the most substance use testing or experimentation happens in 13 to 24-year-olds, for instance. And substance use or experimental use doesn't necessarily result into problematic use or development of a use disorder. But unfortunately for a select group, which we'll talk about, that use or experimentation for a select number of people winds up as problematic use and a use disorder. Now, having said that, there should be awareness that, especially if you look at new onset alcohol use disorder, that you'll see another blip in people in their 60s. And that's thought, especially, for instance, related to retirement or perhaps loss of a spouse. There's new onset alcohol use disorder in people who really had very little alcohol intake prior to that time.
So they're having a big life change.
Right. And in fact, really behooves clinicians to think about and to rescreen for use disorder in individuals who had a life change. The other life change that I think has heightened this risk was during COVID, when we saw individuals who were isolated and older adults who, for instance, for their socialization went to senior centers, and now those senior centers were closed. So that's another time of a social stress or forced isolation that put people at risk.
Wow, that's a really good point. So what is known about the causes of substance abuse disorder and addiction?
I'll just say outright that people who have a substance use disorder aren't morally inferior. They don't have a lack of morals. They aren't criminals. They aren't people who are bad people. So I'll put that to one side. And then when we think about it, certainly we realize there's a genetic predisposition. There are studies of twins in Scandinavia showing that genetics play a role. So lots of studies that show even specific alleles that put people at increased risk of development, for instance, of alcohol use disorder. So genetics does play a large role. I have had patients, especially with alcohol use disorder, who have told me I knew from my first drink that there was something different, that I was going to have a problem. In most instances, those individuals also have a family history. But then the other aspects that certainly play a role are things like social settings and environment. And when you think about, we may talk about in a few minutes about, for instance, adolescence, there are things in their environment that certainly increase that risk, even if there's a genetic component.
I always worry when I still call them children. They don't want to be called children, but they go off to college. So now they're on their own. They're making their own decisions about everything, including if they want to begin any not very good lifestyle behaviors. They might want to participate in alcohol because their roommate does, or experience some drugs for the same reason. And their parents aren't there to be tapping on their bedroom door saying, what's going on in there? Whenever I see that people are packing your kids up to go off to college, that's one of the things that I think about. And I just hope that parents are having that thoughtful, candid discussion with their kids.
Yeah, I agree. I have two daughters who graduated college. I went to college and I saw plenty of misuse and experimentation. And the majority of those individuals that I saw, or my kids saw when they were in college, who ran into problems or may even got into trouble, most of those individuals, as they get older, do not. There's always the argument of how strict versus permissive someone should be related to, especially to alcohol or other. I think the open conversation is really important.
Is it more prevalent in females versus males?
So in most age groups, the prevalence is greater than in males than females. Until that later onset group, for instance, in alcohol, for alcohol use disorder, it's about 2 to 1 male to female. There are some smaller groups of substance use disorders that are more common or more equal for women versus men. For instance, benzodiazepines or sedatives are more equal. But in most instances, there's a predominance of male if you look at PrEP.
Can you tell me about other risk factors that may increase the susceptibility of addiction?
Most of those studies looking at increased risk have been focused on adolescents. The things that have shown significance are early use, so early experimentation. I've met individuals who reported incredibly first use of drugs, including illicit drugs, beyond alcohol at age 8 or 9. A parent with substance use disorder, certainly learning disorders, especially unrecognized learning disorders where attention isn't being paid or accommodation isn't being made. Peers play a huge role. Adolescents are around substance using peers, it's more likely. Then there's also the obvious, which is availability of substances. What substances people use, especially as adolescents, is what they have available.
How about if the young person is an only child? Do you see any difference between having siblings versus not?
I don't know that any studies have shown that. I'm not aware. The other thing I was going to mention, which is really important when we think about adolescents, is that a fair amount of, for instance, adolescent use of prescription drugs is from their parents' medicine cabinet. Certainly, as parents have children reaching adolescence, they really need to take care of not having prescription opioid they got for a dental procedure 3 years ago still sitting around.
That is a really good point. They may even have more than one kind. People do, I'm going to use the word hoard. People do hoard medications, whether it be, you take 3 days of the antibiotic and you feel better, so you're going to save the rest in case you get sick again and you don't want to go to the doctor. I think the same applies for pain medication. Or let me just store this away just in case I need it later, not thinking about who else has access to it. Are there changes in the brain that occur with addiction?
So there are. And in addition, some of the brain chemistry is different between individuals. For instance, for opioids, about 10% of people become purely dysphoric from opioids. They're probably at low risk for addiction. And that's also related to brain chemistry. So there are studies that have looked at, for instance, MRI or PET scan or dynamic imaging of brain in the midst of addiction and even those same people in recovery. And there are changes. The same way we could think about that our brain reacts in different ways in something that we perceive gives a reward versus something that doesn't. For most of us, our brain reaction or our brain chemistry might change when we see an ice cream sundae, and it will change in a different way than when we see a bowl of peas. And there are studies that look at difference in brain chemistry, but there are also studies that look in people who have been in recovery even for 6 to 9 months to show that there is some change in brain chemistry back to what we would view as someone without addiction. There's also properties of the brain that change with time too. For instance, people with addiction, there's a concept called delayed discounting, where in the midst of addiction, and it has to do with brain circuitry as well, that if you ask someone, would you rather have $5 today or $10 in 3 days, the person in the midst of addiction will answer without thinking about it, $5 today, while the person without thinking about it would answer the $10 in 3 days.
Oh, isn't that an interesting question? Wow. Can this also result in destruction of brain cells? Can we forget things from our past, our memory?
Alcohol is a definitive culprit for that. Through its toxic effects, can cause permanent damage in, for instance, the cerebellum, causing problems with balance and coordination that may not be reversible. There's an entity called Wernicke's encephalopathy that can happen from nutritional abnormalities from alcohol use that may or may not be reversible. Those are the classic ones that cause brain damage that may not be reversible.
Let's talk a little bit about the liver. Alcohol in the liver and also drugs get metabolized in the liver. So what does our liver look like later?
Certainly the toxicity of alcohol is especially to the liver. Early on, you can have recovery, but once there is cirrhosis or scarring in the liver, you may not get reversal. Susceptibility cirrhosis of note is also greater in women than men. So for the same amount of alcohol over the same amount of time, women are more likely to develop cirrhosis than men. So definitely something to think about. I've seen many women in only their 30s have cirrhosis related to alcohol. Liver toxicity is worrisome. And as you alluded, medication interactions with alcohol are an issue as well. Many medications require liver metabolism, and there may be impaired clearance as a result of damage from alcohol.
Yeah. What is the difference between addiction and dependency?
Addiction means that there's a constellation of somewhat predictable outcomes related to use of a drug, and usually negative consequences. And it also means that there's pretty classically withdrawal syndrome when someone stops. And that's where we allude to dependency. But there are other medications that produce dependence that we have to stop slowly, but it doesn't mean the person has addiction. So someone could be prescribed opioids for a pain syndrome. Let's say someone in our burn unit or has some injury that lasts a few months and they've been on opioids for a few months. They've taken them exactly as prescribed, but because there's physiologic dependence, they'll have withdrawal when they're stopped, and you have to be careful how you treat the removal of the medication because they have dependence, but they don't necessarily have addiction.
Got it. So is there an intersection between mental health and addiction development?
Strictly speaking, no. Although, as I mentioned, in adolescence, there is some correlation, for instance, between in adolescence with mood disorder and development of a substance use disorder. But having said that, historically, many individuals with a substance use disorder were told they had a mood disorder when it's really difficult to tell, especially, for instance, alcohol, right? So alcohol is a depressant. And in most instances, unless the person stops drinking and you give a few weeks of sobriety, it's unclear whether that depressed mood will remain or was the depressed mood as a result of a exogenous depressant like alcohol.
Wow. Tell me your opinion about the legislation for marijuana. And do you think that this may lead to an increase in addiction? I have been surprised that people seem comfortable driving their car when they've been smoking marijuana, yet they do recognize if they are drinking alcohol, then that's different and that they shouldn't be driving. And for me personally, I put them both in the same bucket. I sure don't want to be in a car with the driver having had either.
Yeah, I agree with you. I find it disturbing when I'm on the Beltway driving and I have to put my car so that no outside ears run in, because while driving, I can smell marijuana cannabis smoke. The early data was from Colorado that showed increased risk related to drug driving, meaning use of cannabis. We don't have the greatest way of measuring impairment based on cannabis use, right? So for alcohol, we can do a breathalyzer and we know that that's been calibrated well, and we know over 0.08 is impaired driving. We currently don't have a good measure, but it certainly seems apparent that individuals should not be driving while using cannabis. So I think cannabis legalization is a tough question because I'll give a slightly complicated answer in that cannabis legalization in one instance made sense in that until then had created a two-tier system where people were able to go to dispensaries who had affluence and money, and most other people would rely on the street. And a lot of the street supply, unfortunately, in 2023 of cannabis could be tainted with other things, including fentanyl. So the other advantage, perhaps at some point, is if we could get cannabis off of Schedule 1 at a federal level, we could do some research to understand better the effects of cannabis and do better studies to understand risks related to cannabis and perhaps other benefits of certain types of cannabis as well. I think we need to be able to examine it, but I certainly don't think anybody should be using cannabis in driving.
Does cannabis affect our brain cells as well? Do we become less intelligent and maybe don't remember things as easily?
So I think that's definitely true for adolescents, that it can impact learning. So a few months ago, one of my 80-year-old patients who's on oxygen and is fairly frail said, "My grandson gave me a cannabis gummy and I think I hallucinated from it." So I think we have to be careful. And I think we should be out in the open of asking patients. I mean, she volunteered that. She didn't have to volunteer that. So I realized that probably for every patient who volunteers, there's probably 4 or 5 who have had something happen who are ashamed and won't admit it.
And don't want to tell anybody. And what an interesting relationship then she has with her grandson. I'm sure he was trying to make her feel better, feel good. He wasn't doing this in a malicious way. He did this because he felt he was helping his grandma. And then he got to see how it wasn't as helpful as he thought it would be, I'm sure. Oh,
And
boy.
I've also had older patients with mild cognitive deficit ask if cannabis will help their memory. And there's certainly no data to support that. There is some data to show that older adults are at increased risk of paranoia from cannabis.
That's pretty scary. There's enough things for us to be paranoid about in this world already. We don't need to add to that list. When we take a look at how to treat addictions, I'd like you to go back maybe 30, 40 years ago. And how did we try to do it then? And how are we doing it now?
Yeah, so I'll take you back even further. So I'm at Johns Hopkins, and I looked up for a grand rounds I gave, what did William Osler have to say about substance use disorders? Not much. His guideline essentially was, all he talked about related to alcohol was that if you see someone who you think is dead, maybe they're drunk. And people who use drugs are inveterate liars. That was his term, which was rather ironic because William Halsted, the founding surgeon of Hopkins, had it alternated between cocaine and morphine use, and would disappear usually at the behest of Osler to go clean up, and he would disappear in a sanitarium in upstate New York and then come back. So historically it was that. And then in the 1930s to 40s, 50s, then we finally got into the founding of AA. And there, that Hopkins history is interesting too, because the successor to William Osler, Dr. Barker, had a daughter with alcohol use disorder who found AA, Alcoholics Anonymous, 12-step group, as what made her stay sober. The idea of 12 steps was to take away blame and to find a support system. So to find people who don't think I'm a bad person, understand that I have a desire not to drink or use drugs, and it's very hard to do by yourself. So that's where we were for many years in how we thought. Again, until 30 years ago, it was the first time there was a shift to realize there's a genetic component. Dr. Saul Snyder here at Hopkins discovered that opiate receptors, and they're brain receptors that help explain why people like the way that drugs make them feel. To understand that we need to look at how drugs make people feel euphoric, and that people like drugs because they like the way it makes them feel. And at some points, unfortunately, all the other negative aspects of use overwhelm that. So for the longest time, we had 12-step groups. And then we started medicalizing and realizing we should be looking at medications. In the 60s, we had the first thought that methadone might be useful for opioid use disorder if we just saturate receptors. And then if someone uses, they don't get the acute euphoria that they would have otherwise gotten. And then for opioid use disorder, we certainly expanded to buprenorphine as well. And then for alcohol, we're kind of in its infancy. We do have pharmacologic agents that we can use for alcohol now, which are quite effective and underused. So I think we're really at the forefront of understanding addiction as a brain disorder with chemistry involved. And I think the new pharmacologic agents are going to be very scientific in trying to, for instance, people looking at, is there a way we can block the impact of cocaine on the brain? So a lot of it, the work is really looking at altering brain chemistry.
How successful are drug rehab programs where someone is going to go away, be away from their family, away from perhaps, hopefully, the source of where they're getting their drugs, and they may be there several months and then they're released? How often does it work versus, they're back at the drug rehab center or they're dead?
That's a tough question because a lot of these drug rehab centers make a lot of money and they charge a lot of money. I mean, there are places that charge 50 grand for 4 weeks. The evidence that they're any better than having someone staying where they are, meaning not necessarily if they're in an unsafe living place where other people are using, you don't want them there. But there's really nothing that says that going away for 4 weeks to a place that looks like a spa, that they're going to create all the tools they need to then succeed when they go back home is not true. And we should always be thinking of medications as well. And we should be carefully thinking about the utility of, if we just separate the person for 4 weeks, then they'll succeed when they get back.
In our family, we had a 28-year-old who had been in drug rehab 3 times for cocaine and heroin. And on the 3rd time, when he was released, that same day, he moved into his girlfriend's apartment, and she had been bouncing in and out of drug rehab. He was there for approximately 6 hours, and he and his girlfriend decided to celebrate that he had been released from rehab. So they both used cocaine that evening. Unfortunately, it was laced with fentanyl, and both of them died. In that building, they found 4 other people dead in another apartment building. We were able to trace, looking at the map of Maryland, where these pockets of 20-year-old young people were found dead. And there was a trail all the way to Baltimore City, and then it went over to the eastern shore of Maryland. And I thought, my goodness, that was certainly a memorable day. But I thought, did the drug rehab center not ask him, where are you going to live now? Or maybe he lied about, who knows? To think that you just got out that day and you're dead before midnight is pretty daggone awful.
Unfortunately, that's not an unusual story. Really
very unfortunate. I've been reading about diabetes drugs, which you see advertised in commercials on television. Ozempic is one of them, for example, and that they may have some benefit for people that have alcohol abuse. Is that true? And if so, how does that work? Are they actually being prescribed?
Those drugs are GLP-1 receptor agonists. They were first originally used for people who were diabetic who didn't respond to first-line therapy. And it was noted not only did they have dramatic improvements in their diabetic control, but they lost a lot of weight. And that's always, before that had been something that was a sore spot in trying to treat diabetes. And some of the medications, for instance, insulin promotes weight gain. So it was noted. Then studies looked at, what about if we gave these class of medications to people who were borderline diabetic or pre-diabetic, and they lost a lot of weight. And that's really where the findings came. If you ask people, it does impact their view of food. And I mentioned how anticipatory eating can actually activate some parts of the brain the same way a drug can. And those circuits seem to be turned off in individuals when they receive the medicines, brand name drugs that you mentioned. Semaglutide is generic. And it does tie into the fact that there's some similar gut-brain connection, and maybe that gut-brain connection is also somehow related to a lot of addiction. So having said that, there is an ongoing trial actually here on the campus here at Hopkins Bayview at National Institute of Drug Abuse on the campus here of using semaglutide for alcohol use disorder. I think it's going to have promise. Now, the other interesting thing, which I didn't mention as a risk factor for alcohol, is that we've seen in people who've had bariatric surgery, especially so-called Roux-en-Y, increased risk for developing alcohol use disorder. Part of it is that they certainly have higher alcohol levels because the alcohol gets into the bloodstream more quickly, but it's probably more than just that. So I've already posed to the researchers here, perhaps when we consider people who are having bariatric surgery, many of them, I think, are going to have received Ozempic or semaglutide, and maybe that will prevent, they may not need bariatric surgery as a result of the medication.
So I was wondering,
Yeah, if they still have it done, it might be a way of trying to prevent an alcohol use disorder in someone who's had bariatric surgery.
So eating disorders is certainly one of those other categories when we're looking at addiction. I was talking to someone about a month ago who is scheduled for bariatric surgery, and she told me, she said, the first thing I think about when I wake up in the morning isn't what am I going to do today or even what day of the week it is. It's what am I going to eat? And I was like, oh my goodness. And I said, will your surgery take that thought away? And she said, well, I'm hoping it will. I frankly didn't have an answer for her, but I was curious about that.
I don't think it will. So I have patients who've had bariatric surgery who have said that their predominant thought for the first few months is that they mourn, mourn, mourn the food that they can no longer eat.
Ah,
And that was a pretty powerful thought. I remember the first person said it to me, and then I had another patient use that same term. I think you still think about it, but you have that distress almost over realizing I can't eat what used to give me pleasure.
yes. So it brought them joy, and now that's been, in essence, taken away.
Although with these medications, I've heard people have used them for weight loss, the food doesn't seem as appealing. They don't use the term that I mourn the food.
Tobacco, nicotine. Can you talk a little bit about that? First, I'll tell you a personal story about myself. I've been at Johns Hopkins over 40 years, so I'm a fixture, I think. After I had worked there a little over 1 year, I started incorporating into every single one of my dreams that I was a chain smoker. And so in my dreams, didn't matter what the dream was about, the environment of my dream, I was smoking Kent or Winston cigarettes. I've never known anybody that would smoke two different brands, but I did in my dreams. And people would tell me, you better cut back on those cigarettes. Oh, I can't. I've got to have my cigarettes. I absolutely have to have them. To the point that in some of my dreams, if I ran out, I remember one of these dreams, walked up to a man and I said, I'll give you a $50 bill if you can give me one cigarette, as long as it's a Kent or Winston cigarette. And he said, I have Kent cigarettes. He gave me one and I gave him a $50 bill. And believe me, if you knew how I was with money, that would never, ever happen. That has continued. I mean, I've now been there over 40 years. I'm still smoking in my dreams. I saw a psychiatrist at Hopkins after this had been going on about 5 or 6 years. And I said, what is this about? I have never even tried a cigarette. Even as a teenager, I've never had a cigarette on my lips, in my lips, wherever that you do that. And he said, you're working through your stress by smoking in your dreams. I said, gee, I've better figure out a better way of doing this. And he said, well, I will tell you this. Don't ever try a cigarette. Don't. He said, you could very well be hooked. I said, in my dreams, I think I feel something going down and coming back up. It is genuinely strange. And it has been with me now for 40 years. I think about that, and I'm empathetic to people that are addicted to tobacco and nicotine because of my experience in my dreams. It's crazy. So I do have empathy. And no one has ever smoked in my family. It wasn't she's got that from her dad no, there aren't smokers in my family. So go figure that. So tell me about, and you could comment about my story too, if you want to.
Cigarettes and nicotine is kind of a mixed story. I just read a statistic that we have the lowest percent of Americans who smoke in the last 100 years. Less than 15% of Americans smoke. The bad news is the fact that we're still worried about electronic cigarette use among adolescents and lung injury. I've seen 2 people in the last 5 years in their 20s who had lung injury from using e-cigarette. So there is some concern. Whether or not e-cigarettes help people come off regular cigarettes, they could be potentially helpful. I always pose to learners the question that if someone has severe alcohol use disorder, what cancer are they at the most risk of dying from? And the answer actually is lung cancer, because 95% of people with alcohol use disorder also smoke cigarettes. So nicotine goes with other substances. Certainly there's synergistic or additive risk with the fact that people use other substances have a really high likelihood that they're also cigarette smokers. But I think it is good news for us and not for the tobacco companies that we are seeing continued decline in cigarette smoking in the United States.
Do you think that we have a lower volume of people smoking today, not just because of the ability to vape, but also because of the cost of cigarettes?
So there's clear data that cigarette taxes impact smoking. I've had patients who are still trying to quit smoking who will say that they can't believe they spend $12, $13 for a pack of cigarettes. So it's expensive. And there is clear evidence that cigarette taxes clearly had a role in the decreasing number of Americans who smoke.
I've had a couple of friends that have quit smoking, and I told them as they were trying to wean themselves off, I said, take that money that you normally would be buying your cigarettes with and put it in a jar. And at the end of a year, when you then are a non-smoker, see how much is in there and go spend it on something that you have always said, gee, I wish I could afford to buy whatever. And I said it could be a vacation, it could be, I don't know, it could be a motorcycle. I don't know what it'd be. I don't think that people want to pay attention day to day of how much they're spending because that would be too glaring and obvious. You put that money in that jar over there, and then I think you'll have a real appreciation for how you could spend this money in another way. That could bring you joy. I did emphasize that. I said, it's not that you're paying off your credit card. You're going to go spend this on something that's going to bring you joy. So, what other effective treatment options are available for the various substance abuse disorders? We've talked about medications, we've talked about methadone and such as well. Does hypnosis do anything? Does meditation do anything?
So those are hard to prove. I think there's certainly no downside. It's tough to do to do a controlled study to show sham hypnosis or sham yoga. I certainly think things like physical activity and yoga and meditation are part of shifting to a healthier lifestyle. I mean, the other things that we've looked at, for instance, we're really lacking is treating stimulants, whether it be methamphetamine or cocaine. We don't have great treatments for stimulants. For the first time, there's now been approval for use of contingency management. Contingency management is the fact that you give a reward for not using, and it's usually financial. I've done studies here at Hopkins in the Center for Learning and Health using contingency management where people can get job training and they get paid on the basis of their, for instance, their urine drug screens being negative for substance that they've been using, such as a stimulant. Rather than the negative, meaning we caught you, you're bad, you've managed to not use, you get a reward. I mean, in our lives, contingency management is why hopefully we drive safely, because we know if we drive safely, our auto insurance costs less.
Mm-hmm.
So much of our lives is based in an indirect way on contingency management. And people will say, well, why should you be paying someone for what they should be doing anyway? That's not necessarily valid. I know within Hopkins, you can get, if you show evidence of exercise regimens or taking care of health maintenance, you can get a discount or actually get money back. It's the fact that a contingency helps people, especially when we think of things like stimulants, where we don't otherwise have a good way of treating. The other medications, which you may be leaning towards, they've received a lot of press because they're hot topics, are, I'll mention each one separately, ketamine, which is an anesthesia agent, but there's also an agent that's been misused and can be used illicitly, but there is data, for instance, to look at ketamine infusions for refractory depression, and also some data now looking at ketamine infusions for things like refractory alcohol use disorder. So I think we're going to see emerging studies. And then the other hot topic is psilocybin, which most people know is hallucinogenic mushroom. Roland Griffiths here at Hopkins had done a lot of pioneering work in his psychedelic center, initially not looking at it as a treatment for substance disorders, but rather some of his initial studies, for instance, looking at its use in people with end-stage cancer, creating peace in their life and their emotion. And then he did some studies looking at it for people with refractory smoking, and it seemed to be useful. And I think we're going to see more looks at psilocybin. Having said that, of course, we have to create the balance. In some places, for instance, California, psilocybin is a very illicitly used drug. I just saw some data from a few months ago looking at Reddit, which is online, mentions psilocybin is really mentioned a lot. It's the fourth most misused illicit substance in California now. So I think it has hope, and the hope is that we find a way to effectively do correct research on it for both of them, for both ketamine and for psilocybin.
So you mentioned about end-stage cancer patients, and I am familiar with that study because I work in the oncology space. What have been the outcomes thus far? Have patients been willingly signing up to participate in the clinical trial? And then in retrospect, were they glad that they signed up?
The answer is yes to both. Early on, in order to do the psilocybin research, I had to be a medical backup here on the campus. When they administered psilocybin 10 years ago, because of the fact that it was more unknown, there had to be an internist like myself somewhere nearby that could go running if something happened. There were no untoward effects in any of the studies using psilocybin under experimental conditions. With the interests, including Roland Griffiths being on 60 Minutes a few years ago, and increased funding with interest of psychedelics, the interest has really heightened.
That's good. Well, I know that Hopkins is certainly on the forefront of that. Are there other research studies that are going on that you would like to tell us about?
There are additional ones looking at impacting alcohol use disorder, including some old drugs like spironolactone, which is used as an antiandrogen. It's used in heart failure. It's used in so many other settings that seem to have an effect. And it's an inexpensive medication that perhaps has an effect on people with severe alcohol use disorder. More and more, we're going to be looking at, there's a thought of, could there be a, quote, vaccine that prevents cocaine use? There's some research now looking at, is there a way different than a pure opioid blocker to prevent the impact of fentanyl and prevent respiratory depression, which is what people die from fentanyl use? Pharmacotherapy is especially, or novel ways of preventing things like fentanyl overdose are going to be on the forefront.
Is there anything I haven't asked you that you would like to include in our discussion today?
So I was just going to add a philosophy, if that's okay.
Sure.
When I see somebody with a substance use disorder, these are the terms I bring up to the forefront. It's recognize that most people with a substance use disorder have shame, and the shame is usually self-inflicted. And related to that shame is poor self-esteem. And I have a cartoon I share with patients where a provider says to a patient, the best that you can do for yourself is not drink. And the patient says back, well, I don't deserve the best. What else can I do? So that's where a lot of our individuals are. And I think we have to recognize that. Even for patients in recovery, coping is something that's really hard. I openly always talk to patients about how do you cope with a bad day? And then we also talk about anticipatory coping. Are there days that would make you more vulnerable? And we talk about what to do when feeling vulnerable and what are safe ways to cope. And then the last thing is the obvious, is that as we had this discussion, is to offer people, communities, individuals that we have hope, that there are effective treatments, and that we got to keep on having hope that we're going to have an impact.
What advice do you give to parents who have a teenager or young adult that they've deciphered from their behaviors that they have addiction?
So a lot of it becomes a family illness. So I also don't want the parents to feel that they're to blame. It's also a message of hope. For adolescents, it's a complicated process, right? Because there's a lot of that has to be impacted. And especially for adolescents, their peers play a huge role. And it's sometimes particularly difficult for adolescents to change their peers.
Almost impossible unless you move or you're placed in maybe a different school, perhaps a different school system. Yeah. First, I want to tell you, thank you ever so much. This has been a wonderful educational opportunity for our listeners, but also for me. Having been at Hopkins a very long time, I have come to discover that there are always things going on that I am not aware of. However, I take great pride in knowing that these things are happening within Johns Hopkins and that we are in the forefront, I believe, of as to how to help families and individuals so that they can live a better and more productive life and still have it factored in that they have great joy in their life.
Thank you.
Let me also say to our listening audience, to receive additional information about other women's health issues, please visit A Woman's Journey website at Johns Hopkins Medicine. The address for it is hopkinsmedicine.org/A Woman's Journey to sign up for our monthly e-letter, read about upcoming podcasts, to sign up for our upcoming free Conversations That Matter webcasts, and learn about our live programs. Thank you for listening, and I hope you will join me next month for another educational and information podcast featuring another Johns Hopkins Medicine expert.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lily Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/A Woman's Journey. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/A Woman's Journey. Until next time, stay well.